Good afternoon. I'm presenting today metastatic lung cancer to the distal finger, presenting as osteomyelitis. The distal phalanx is a rare site of metastatic disease. It's often misdiagnosed as osteomyelitis because of clinical features, symptoms, and radiological findings. If preceded by trauma, the diagnosis may be particularly difficult. We present a case of a distal finger laceration which was initially diagnosed as a superficial skin infection that progressed to osteomyelitis, but subsequently found to be a metastatic lesion. We also present a proposed mechanism for this unusual metastatic site. There are only a few similar cases in the literature and none with definite history of antecedent trauma. 69-year-old male, cigarette smoker, presented with pain and swelling in the right second digit for 2 months duration. That began when he lacerated his finger with clippers. The lesion gradually enlarged and became erythematous. He received multiple courses of oral antibiotics with no improvement. He then sought care at an outside hospital emergency room. Based on radiological studies, he was diagnosed with osteomyelitis and scheduled for elective surgery. Shortly afterwards, the finger began hemorrhaging and he presented to our institution. At that time, the distal phalanx was markedly inflamed, tender, and showed signs of recent hemorrhage. Plain films and CT of the digit revealed erosion of the second distal phalanx felt to be osteomyelitis, and the plan was to do elective surgery for him. On admission, he had a normal white blood cells and ESR. A chest X-ray revealed a left lower lobe infiltrate, and a CT of the chest demonstrated a 6 centimeter mass in the left lower lobe, which was biopsied. Pathological diagnosis was poorly differentiated carcinoma. The finger was amputated, and biopsy revealed similar pathology. We want to highlight that acrometastases are rare, representing only 0.1% of all skeletal metastases. The lung is the most common primary site of origin for acrometastases, 40 to 50%, and squamous cell cancer of the lung is the most common type of histology. The mechanism behind acrometastases are not well defined, but both experimental and clinical evidence support the hypothesis that sites of antecedent trauma provide fertile ground for cancer cells to plant themselves and grow into metastatic lesions. The wound healing process can be hijacked by tumors to promote invasion and metastasis. Part of wound healing process involves increased local level of epidermal growth factor and factor follistatin like 1. Squamous cell cancer of the lung is rich in epidermal growth factor receptors with a 2.5-fold greater number than that of normal skin. Epidermal growth factor levels and other factors are increased at the site of the wound. Also, trauma and even microtrauma may contribute in the pathogenesis of acrometastasis. As recent literature shows, the dominant hand more frequently developed acrometastasis. Factor follistatin like 1 promotes expression of matrix meatoprotein 9, which can degrade extracellular matrix through effect on mitogene activated protein kinase signaling. So this will enhance the likelihood of metastasis to that area. We conclude that certain malignancies have increased receptors for wound healing factors. For these malignancies, trauma will promote local metastasis by releasing wound healing factors that create a favorable environment for micrometastasis cell growth. Also, we conclude that some of these components are and others may be future targets for therapy. Finally, metastasis should be considered in any patient with unusually persistent post-traumatic inflammation and/or infection. Thank you.